Welcome everyone to today's webinar. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Maureen Spencer has been an infection preventionist for over 30 years and is board certified in infection control. Maureen is currently an infection preventionist consultant working across the U.S. Previously, she was the Director of Clinical Implementation at Accelerate Diagnostics, facilitating clinical implementation sessions at a fast antibiotic susceptibility system for bloodstream infections and sepsis with clinicians and staff. Prior to that, she was the Corporate Director of Infection Prevention for Universal Health Services, overseeing their 28-hospital system in 7 states. As one of the early pioneers in infection control, Maureen was awarded the APIC National Carol DeMille Award in 1990 and was selected as one of the APIC Heroes of Infection Prevention in 2007 for her work in establishing a MRSA and Staph aureus elimination program at New England Baptist Hospital in Boston. At this time, I am pleased to turn the floor over to Maureen to begin today's presentation.
Thank you, Mackenzie. So today I'm going to talk about quality improvement in surgical settings and the importance of perioperative standardization. So I'm going to describe some of the trends in infection rates and public awareness of cost implications in standardization. I'm going to also talk about the role of quality improvement. Let me get this over here, sorry. Quality improvement and standardization, identify key initiatives to manage risk factors in surgical care, and why we should be focusing on improving patient skin preparation in surgical care, and illustrate the implementation process with some case studies. We're going to first look at healthcare-associated infections as a quality issue. And if you look at this chart, you actually have a greater risk of developing a hospital-acquired infection, then losing your luggage on an airline, or having a U.S. airline flight fatality, or even anesthesia-related fatality. And this is one of the reasons that we've been looking at the airline industry in healthcare. So how do they actually do it so well? And what are some of their standardization protocols and processes that they use and tools that we're now starting to implement into healthcare? So the resistant strains are increasing rapidly. We actually have more MRSA, we have VRE, vancomycin-resistant enterococcus, and more worrisome of the fluoroquinolone-resistant Pseudomonas aeruginosus. So CDC has published some information recently saying that by the year 2050, if we don't get our antimicrobial stewardship programs, up and running and really starting to control the inappropriate use of antimicrobials, by the year 2050, over 10 million people will die as a result of an antimicrobial resistant infection. And that's more than cancer, diabetes, and other kinds of health conditions and events like road traffic accidents. So the resistance is becoming more common with increased resistance, such as 46% of Staph aureus HAIs that were meth resistant, 14% of Pseudomonas HAIs that were multiple drug resistant, even E. coli that tended to be very sensitive and now getting resistant, and also the enterobacters. And these populations that we're seeing these resistant strains are those that have chemotherapy and have immunosuppressed states, the surgical patients, and things like rheumatoid arthritis, dialysis, and organ transplants. Again, patients that have compromised immune systems. And these are a threat to our patient care and our quality of our care. And so that's why prevention is key. And that's what infection preventionists do. They pull together HAI bundles and protocols to provide consistent, safer care in the inpatient, outpatient setting with really good processes that are standardized. So standardization relies on a systemic quality improvement approach. And there are 4 principles of quality improvement in healthcare. And the number one is that the patient comes first, that the entire reason you do it and the focus is on the patient. Followed by data drives your program. And that's why you want to be able to collect whether it's processes and observations on how people are doing particular procedures and processes, or it's patient outcomes, which we know that the infection preventionists collect information on healthcare-acquired infections and report those to the National Safety Health Administration at the CDC. And that program then works with CMS to report these as publicly reported information. So if you're not working closely with your infection preventionists, you want to, for your teamwork, be a part of a team to include them. And that's where you start to implement the quality improvement systems and processes that will help you be able to get your quality program up and running. There are many different standardization bundles that have been implemented. Years ago, we started to focus on central line associated infections called CLABSIs, and there are bundles for that, checklists and various kinds of products that can be used. And then they went into ventilator associated pneumonia and developed VAP bundles. We also have catheter associated urinary tract infection bundles or CAUTI bundles. There are some C. difficile bundles, and there are several different kinds of bundles that have been published relating to surgical site infections. But this is very important to be able to minimize your variability in your processes and get things standardized. When you have high variation, you have the high potential for defects because you have unpredictable quality. And the key is to be able to get your staff on board and to buy into low variation, start to do things with consistency and have consistent quality. So the surgical practice bundles are tools that you can use in clinical practices that will start to decrease some of this variability. So first you look at what is the potential for great harm and identify some of your risk factors, and your data should be providing you for various kinds of outcomes that you want to look at. And then develop that strong evidence base by looking at evidence-based practices in medicine, bringing that to your committee, and the other is to reduce costs because variation increases costs. So one of the programs that's been used successfully from ahrq.gov is what's called the Cusp Program, a comprehensive unit-based safety program that this is a model for improving quality because it leverages different methodologies. The first is to identify your defects, and then you want to learn from those defects. There are many that do a RCA, a root cause analysis now, even for infections, and try to learn from those. Why did this happen and what went wrong? Then you educate your staff in the science of safety. You engage your executive leaders, and you implement teamwork with those tools. So here's what's called a Fishbone Diagram. I actually had the opportunity to work with a team of surgeons and operating room nurses, actually in Malaysia years ago. And we pulled together in the teamwork workshop that we did, this particular kind of what's called a fishbone, looking at patient factors, perioperative team factors, organizational management factors. We also looked at the patient factors, surgeon factors, work environmental factors, and care delivery problems, identifying those different defects that could lead to failure. In this particular study from the American Journal of Infection Control back in 2013, out of 71 hospitals that were surveyed, they found that antimicrobials being given within 1 hour to incision had a high compliance rate of 98%. But actually, I have to warn you about that. If they give it within 2 minutes to incision time, or give it out at 58 minutes to incision time, okay, they're going to meet the criteria. But the problem is if you do not get those antibiotics in at least 30 minutes or so to get tissue penetration so that when the surgeon does do the incision, there's actually antibiotics in the incision, or vancomycin has to have an hour prior to incision time. So you can work with your quality improvement nurses that collect some of this information and actually ask them what percentage of patients received their antibiotic less than, say, 10 minutes to incision time. That may be one issue that's going on. Also making sure the antimicrobial doses are based on weight. That's an area that only 64% were doing that. Hair removal by clippers, very high compliance with that. So almost everybody's gone away from using razors. Pre-op glucose monitoring, especially in high-risk populations like the cardiac population and obviously diabetics. The perioperative temperature evaluation, skin prep when used prior to colorectal surgery, and skin prep prior to use for abdominal hysterectomies had high compliance. And then education regarding scrub techniques within the past year. There was only 58% compliance with that. And that's something we'll talk about. It's really important that you keep educating and reinforcing with your staff the importance of how to do scrub techniques appropriately according to the manufacturer's recommendations. So improvement must be multidimensional. To have a successful standardization HAI program, as described in this paper in 2016 in the International Surgery Journal, you want to simplify your processes and procedures and make sure that your personnel have competency-based methods and they use tools that are going to help them to improve processes. So if we look at variation in skin prep, there are many opportunities for standardization. So this paper in what we call ICHG, Infection Control and Hospital Epidemiology, many years ago, and also from ARN, these are the domains that we want to make sure that we meet for opportunities for skin prep. The first being as simple as hand hygiene. And maybe you need to do some observational studies of your staff's hand hygiene procedures. And do they really know how to do the second one, hand and forearm scrubbing techniques, making sure they know your products that you brought in, especially your residents, by the way, and PAs that may not get that reinforcement. We're very good at nurses and maybe your scrub techs, but make sure that you're also giving that education to residents and fellows and PAs on scrub technique, scrub duration, and then the drying and gloving technique. Also hair removal, that this should be done outside the operating room preferably. If not, consider using that vacuum-assisted hair removal device, which I'll mention a little bit more information shortly. Only around the incision site where the hair would interfere with the operation should that hair be removed. And prevent abrasions by using electric clippers and not having any hair removals with razors. And the last is surgical site antiseptics, making sure your staff understand what the agent is, the application method, and more importantly, the dry time, especially if they're using the alcohol-based antiseptics because of the risk of having a fire in the operating room. They do not dry it properly. So in this paper here, this was actually presented at the ARN Congress in 2014, and this was over 3,000 observations in 197 facilities where they looked at various different types of antiseptics to see were the processes followed. And the skin prep application time being sufficient was only 60%. Skin prep drying time was sufficient in only 53%. Gloves being used for the skin prep application had a high compliance of 91%. Should be 100%. But skin prep application where they followed the label directions was only 63%. And then the skin prep application from surgical site to the periphery of the field was only 86%. Again, one that should reach 100% if they're following the IFUs from the manufacturers. So the other applications that were looked at were whether they were CHG with isopropyl alcohol, the iodine with isopropyl alcohol, aqueous CHG or iodine scrub and paint. And so each manufacturer will give you these IFUs. And so you can see here under the ChloraPrep, they recommend this gentle back and forth stroking for duration of anywhere from 0.5 to 2 minutes, okay, with a dry time of more than 3 minutes. DuraPrep or Prevail, paint in concentric circles. So this is going to be different than the CHG. Having, at least more than 0.5 minutes. And again, this is important, a dry time. I think we focus so much with great education by the company reps for the CHG and isopropyl alcohol and making sure that that 3-minute time was met. I think that people forgot that you also have to do that with your iodine preps that have alcohol in them. If it's just the aqueous CHG, that would just be a back and forth method for minutes and blotting it dry. And the scrub and paint would be concentric circles for 5 minutes and a dry time of 2 to 3 minutes. So this is really important for your team when you sit down and start to look at standardization. So you find out what antiseptics you are using in the operating room, get the IFUs from the manufacturers, information for use, and then sit down and develop some educational programs, webinars, or online different types of programs your staff could take for their competencies. So here's a paper that was actually presented at OR Manager Conference in 2014, looking at almost 5,500 procedures in 257 hospitals back in 2013 to 14, looking at directions for use. And they found that the iodine in alcohol with chlorhexidine in alcohol, if it was a one-step skin prep, this yielded much greater clinical efficacy, time saving for the staff that could impact the overall quality versus the scrub and paint, where they then had to remember 2 steps versus just the ease of having a 1-step for standardization. So in this paper published in 2016 in the International Surgical Journal, okay, they looked at whether they either had the prep time, according to the IFUs, only 61% compliance, but if they looked at both prep time and dry time, it even reduced further to 25%. So the point is there's a lot of literature showing that we have issues with standardization when it comes to using skin preps. So some of those factors with higher compliance in the 61% was the one-step applicators, the central to peripheral application, the use of the chlorhexidine and alcohol, and performing a single prep. In these 2 papers that were in the Journal of Bone and Joint Surgery, they looked at positive cultures after the prep with these various antiseptics in both of these papers. And you can see that a chlorhexidine prep with the alcohol had a lower positive culture after prep than the one iodophor or iodine with alcohol or povidone iodine. And in the second paper, they even looked at Technicare, which is the benzalkonium chloride type of product. And so again, the chlorhexidine or chlorprep had much lower positive cultures after prepping than the other products. And so variability in surgeon antiseptic technique. They looked at 30 subjects who routinely prepped in 4 hospitals to participate in this study. And they looked at the recommended time, the sterile technique, whether all the steps and critical steps were followed, and the prep times. And you can see again that chlorhexidine with isopropyl alcohol had very good compliance with recommended time, had a lower level of the technique itself, as well as all the steps versus the povidone iodine. The critical steps were 90% with chlorhexidine versus only 33% with povidone iodine, and the prep time was less. Again, a single step that incorporates the 2 products together rather than have a 2-step approach as a better outcome. So surgical clipping and the challenges and opportunities for improvement. Here was an online survey of 250 members from ARN, the database, with 2 years of OR experience and at least 2 procedures requiring surgical site hair removal to participate in this particular survey. And they recommended clipping with the standards instead of shaving, that 98% said that's what they did, using a single-use clipper, 96%, but clipping outside the operating room, only 40%. So that they did that outside the operating room. And the reasons for clipping in the OR, the highest reason was the physician preference, 67%. And that was followed by patient safety privacy issues. Insufficient clipping outside of the operating room, lack of time, or maybe they had no set policy at their institution or didn't know there was a policy. They followed the ARN guidelines. There would be guidelines, but may not necessarily a policy. Lack of trained staff and nursing staff preference. And the other issue that had a small level of issue was the lack of space, nowhere that they really felt that they could do it outside the operating room. Why is this a problem? It's because the body in various areas have different colony counts of organisms. And you can see the amount of organisms that are in the colon or down in the perineum versus, say, the foot or up near the eye and the face. Around the mouth is a much higher, 10 to the 9th. 10 to the 9th to 11 in the colorectal area. So those are some of the things that proper skin prep is critical to prevent possible complications from what we call endogenous contamination, the patient's own flora contaminating either the surgical case itself or getting around the patient's skin. And so that's why it's really important to clip and take the hair that gets contaminated off of the body to remove that link to the potential for an infection. If you look in the literature, there are several papers that do show organisms that were traced from the hair or scalp, especially with Staph aureus and Group A strep. And these are identified in a really good paper in the Airline Journal back in January 2014 by Dr. John Boyce. And the whole article is on the role, why it's important for us to have hair coverage. It's part of our surgical attire. And it has a very nice list of some of these articles and papers that show the outbreaks that have occurred from hair. So clip or not to clip? First of all, if you don't have to clip, you don't, if there's not that much hair to remove. But in procedures where they are going to probably have hair removal, it would be orthopedic lower extremities, the cardiovascular area, obviously OBGYN and even urology, neurosurgery for the head, and then orthopedics upper extremities. So ARN recommends that you do it outside the operating room because, as I showed, the areas of the body that can have very high levels of contamination. You don't want to be clipping in the operating room and having that hair move all over with all the movement that goes on in rooms when they're getting a case ready. Doors are opening and closing, staff are moving around getting things ready. And so therefore, if you have to do it in the operating room, there are some different kinds of approaches that we could take to standardize that. The reasons, though, inside the OR, as you notice, the physician was the highest reason that they clipped in the OR. And the number one is patient privacy. To clip somebody who's having a GYN procedure or urology procedure maybe out in the pre-op holding area, there's really a lack of privacy behind these cubicle curtains. So therefore, they also want to reduce the potential of delay, or maybe it's an emergency surgery, and preference to clip under anesthesia. That seems to be the one that I've most encountered. And then the training of the staff. And so hair removal should be performed the day of the surgery in a location outside the operating room if possible. Only hair interfering with the surgical procedure should be removed. Hair should be clipped using a single-use electric or battery-operated clipper, or clipper with a reusable head that can be disinfected between patients. Now that's something, again, the years that I did operating room observational surveys, which our team would come in and do a joint commission and CMS survey for our hospitals when I worked at UHS. This was one of the things that I would look at, the condition of batteries and of clippers and whether they were, using reusable heads and so forth between patients. Another issue that you might see are situations like this, where the clippers are harming the patient's skin. And this is if the staff have not been trained in the proper way to clip. And this can result in cancellation or delay in surgery. If the surgeon looks at this, they may not want to do an incision through this kind of injured skin. So there are vacuum-assisted technology. You can see the picture here of the vacuum-assisted device from VD. And this is a much better system where this will actually collect all of that hair and take it through this vacuum, and then you can just confine and contain this hair that's got contamination on it. So again, these clippers have to get clean between patients. A lot of times staff will take the top of it off but forget to clean the clipper. And the other issue is tape is often used. Pieces of tape that they grab from these bins. Somebody has to clean these bins, these blue bins or yellow bins where we hold tape, and have the sticky part of that tape gets all contaminated with organisms. You can show your staff easily by getting the laboratory involved with you and get some blood agar plates. I've done this in the past where I would take rolls of tape and just imprint them on the blood agar plates, incubate them, and let them see what's growing on the tape the next day. And so that's just to illustrate for them why this is an issue, that the tapes get contaminated, and yet you're trying to go around, pick up the hair from the clipping. And that's why these kinds of devices are much better where it confines and contains that contaminated hair. So in this study was published in the American Journal of Infection Control by Dr. Edmondson and a team in 2016. They actually did a simulated surgical clipping study of 18 subjects. And they wanted to look at the problem of microbes contaminating the operative field and hair being dispersed from these clippers, especially requiring a lengthy cleanup time, and replacing the standard clippers with this vacuum-assisted hair device to limit the opportunities of contamination and improve the surgical team efficiency. And the result was significant reduction in microbial contamination from chest samples when they compared the standard surgical clippers to the vacuum-assisted hair device in the colony-forming units. So in this particular paper, he looked at hair being removed at the point of clipping, the microbial contamination in the field, and showed it was just statistically significantly reduced when they used the vacuum-assisted device. So here's a few case studies that I'm going to review looking at practice bundles of standardizing skin prep. And this is from an ambulatory surgery center in East Tennessee that looked at surgical site infection standardization in a very highly productive ambulatory surgery center. And they looked at the post-procedure infection rates that were rising, and they wanted to complete a QAPI, which the quality assessment performance improvement in preparation for the next accreditation review. And they implemented evidence-based review of existing practices that they want to develop clinical practice bundles to create a standardized program and implement training. And their result at the end of that was that they had significant reduction in more than 80% of the SSIs post-procedure with this high consistency of their practice standards. So they looked at multiple day observations of their existing product use and practices, and they developed the data, they collected the data and then presented the data to the director of nursing to look at then starting to get clinical standards, guidelines, and industry practice standards and consolidate the variation in product use. And they use this multi-pronged educational strategy that include in-services, direct hand-on practice, printed product reviews, and visual practice posters in the OR. And their result was that they increased staff consistency of practice, they improved their post-procedure infection rates, they had great staff satisfaction, there was less to remember, so that's the real goal with standardization, reduce the number of variabilities in the steps in the procedure so that things can get standardized, and you improve patient satisfaction and perceived patient care. Everybody's doing it the same way consistently. Now here's another initiating quality improvement in surgery, a systematic approach. In this situation, let's see if I can just move this over here, as clinicians and consultants observed the operating room procedures. They looked at surgeon hand scrub, hair removal, and patient preoperative skin prep. They monitored observations that they collected daily and then recorded that on a mobile device. They then looked at the compliance with product directions, the clinical practice guidelines, and practice standards. And then they calculated and reported out the percent compliance and tried to uncover areas that could be improved with standardization and education. So that they focused on team training, evidence-based guidelines, and regular review and reinforcement of their competencies. So here you can see a really good QAPI program that was put in place at that institution. So when you implement a standardized approach with procedures that reduce variation, you have to engage your staff. You commit them to first reducing variation and find out actually from them. You can use mind mapping, brainstorming techniques where you ask them what they think causes some of that variation and get them communicating and get a commitment that they all participate and buy in and engage the patients as well. You educate and you use your OR audit tools to assess current state, analyze your procedures with competency workbooks, train your staff on new processes and assess patient understanding. Develop your action plan, implement new processes and leverage your clinical job aids, and educate patients on proper pre-op and preparation at home. So that's really important that patients understand if you assign them to do a CHG shower, or you don't actually give them the product, but you recommend that they go to a pharmacy and they purchase CHG. Make sure they have written instructions on how to do a proper CHG shower. If they're involved with the liquid, it should be standardized that they actually put it on and leave it on for 1 minute so it can penetrate the skin. That was unfortunately what happened in the past, that we didn't really have really good standardized educational materials for patients, so therefore they were not doing their showers properly. And then you want to make sure that you collect your observations. You then do some competency testing and communicate the successes and your failures to your team. So here's a study of Surgical Comprehensive Unit-Based Safety Program, or Cusp Program, for SSI prevention at Johns Hopkins University. And they found that nearly a third of the patients that were undergoing elective colorectal surgery were developing HAIs after surgery. The solution was to put together a multidimensional collaborative approach that used evidence-based quality improvement strategies. And their result was a 33% decrease in their infection rates 12 months after the intervention. And they published these results in the Journal of the American College of Surgery in 2012. So for successful HAI reduction, they involved infection control. They looked at their policies and protocols. They looked at all the equipment and supplies that we used for that type of surgery, how they were communicating to the staff and the teamwork that was involved, how they coordinated care and education and training. And so they felt that the targeted changes that contributed to the success was evidence-based elimination of mechanical bowel prep for select patients only, instituting aggressive warming procedures for the patients in the pre-anesthesia area. Many institutions will warm the patients in surgery, but they need to be warmed prior. So the immune system is working well, the cells are moving through the body, so that you really can have a good immune response and hemodynamics as far as the platelets and so forth. Patients are cold, that can affect both the immune system and the platelets. Adopting consistent processes, enhancing sterile techniques for skin and fascial closure, and using techniques that promoted standardized adoption and created redundancy in their processes to correct lapses in their antibiotic prophylaxis that were brought to light by the compliance audit. So again, data drives your program. It's really important. They can be tedious, to do some of these observational studies, but if you can take your time to develop some checklists based on evidence-based articles and papers and other published checklists, and go in and just do a survey to see how you're doing, and then get the team together using that data, and then start to look at your strategies for success. And so some of the things they looked at was the chlorhexidine versus the povidone iodine solution. They were having issues with how that was being used prior, and afterwards the chlorhexidine gluconate was used for all the patients, including those for ostomies. They looked at application technique and who was actually doing the application. They also looked at how they were preparing around the area of the ostomy and having patients not involved and they were consistently engaged in pre-op skin prep. And so again, the GI surgery nurses were trained on the prep application, and now only those team members could apply skin prep agents. And all patients were given chlorhexidine CHG washcloths the night before. And then they interviewed the patients and found they had a very good high compliance rate of 95%. They also looked at the instruments that were being used to close for skin closure in the field, and whether these instruments remained in the surgical field. If they're contaminated from the colon, which has 9 to 11, 10 to the 9th to the 11th bacteria in the colon, you want to make sure that those instruments aren't contaminating the ones that will be used for closure. And lack of standardized education on sterile technique and processes. After the teamwork, they designated instruments to be used exclusively for bowel manipulation. The instruments were physically moved off the sterile field after the anastomosis was done. The cautery and the suction tip was changed, and they put together an education plan to implement and train the nurses and scrub techs to separate instruments and change the entire team's gloves, both after completing bowel work, but also before starting the wound closure. And you can see the statistically significant reduction and the overall infection rate, but they also broke it down by superficial, but also by organ space infections. We typically, when we look at superficial infections, as an infection preventionist, we're looking at what's going on with the closure, the end of the operation, where there's a lot of activity in the room and somebody is still sewing that incision together before they're going to now put a dressing on it and move the patient out. Then they get to the nursing unit and home care. So you look for superficials more along those lines. But organ space infections, we typically are looking at what's going on in the field or in the operating room as far as infections. The point being that you can't just look at an overall infection rate nowadays. You want your infection preventionist to stratify the data for your team on what percentage of them are superficial, deep, or organ space. And also, the data they're putting into NHSN, they're going to get a standardized infection ratio, an SIR. And what will happen is they will get from CDC, once they upload all your surgical files, I'm not sure you all realize what the IPs do, they have to take all of the surgeries and upload them to CDC's NHSN. And then they put in how many infections they had. And CDC will tell them what number of infections you're likely to expect based on the database they have in the country for that volume of surgery. Then they put in how many they did have, and then they calculate what's called an SIR, a ratio based on that. And that's a risk-adjusted ratio. So we're kind of getting away from just looking at infection rates and better off the SIRs. So the two that you can get SIRs right now from CDC are for colorectal and abdominal hysterectomies. As time goes on, there'll be many more that will be in that system that you'll be able to look at. And so the real important thing with their results was that the rate of HAIs decreased by 33%. They actually had 28 less infections in a single year. Now, I would have costed that out, which they did, and you would see that's anywhere from 168 to 280,000 that was saved by that institution. An infection, an SSI roughly is about $25,000 to $30,000. But again, it depends on the organism, depends on the surgery. Orthopedics cost clearly more. I worked in an orthopedic hospital for infection control, and we costed out our infections, and many of them were over $100,000. And so if you look at the whole healthcare system itself, you can have significant cost savings with these types of programs, anywhere from 102 to 170 million in healthcare savings costs with this kind of work in teamwork. So in conclusion, HAIs are evolving, they're threatening patient safety and the delivery of quality care. Safety and quality improvement to mitigate the risk of HAIs can be achieved with standardization. Your processes, your technologies, even product use, behaviors selected for standardization should be grounded in evidence. And there are many opportunities for standardization in surgery, especially around skin preparation, clipping, surgical clipping is another one, the antibiotic prophylaxis, as I mentioned earlier, and any of your policies and procedures are put in place with your bundles that are intended to minimize the risk. And you can contact your local BD rep to discuss how they might help you advance these standardization initiatives. I have worked very successfully with many of the vendors in different types of surgeries and products and protocols. And BD, they're fantastic, the program they have in place. I showed you a couple of papers I actually presented at ARN and OR Manager on the work that they do in hospitals in trying to develop standardization initiatives and help them to reduce their SSIs. So now I'm gonna put it back over to Mackenzie so we can open it up to any questions that you might have.
Great, thank you so much, Maureen. We'll now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to answer as many questions as we have time for. Looks like we already have a lot of great questions rolling in. And the first one is from an audience member who wants to know, which prep would you advise to give a patient to wash at home, day before, and the day of surgery?
Well, I actually was fortunate to have been on a couple of papers that we published in the American College of Surgeons and AJIC, Infection Control, on looking at CHG. So what's unique about chlorhexidine versus some of the other antiseptics is chlorhexidine is a positively charged molecule. And what it does, it binds to the cell wall in the tissue, in the bacteria, to the cell wall, and it rapidly is uptaked, and then it damages the cell wall. It's kind of like how antibiotics work. They go in and do what's called cell wall synthesis and destroy the organism's cell wall. So everything kind of, the cytoplasm squirts out, and I always call it the suicidal effect. They basically commit suicide. And so that's why it's so important to use CHG. Some of the others, especially, the iodines, are not that good, don't have as good activity in the presence of blood and mucus. They're really meant to be for the top of the skin. But CHG is a great product, especially the liquid the night before, but you have to give them a 4-ounce bottle. I recommend they purchase a 4-ounce bottle. Many of the pharmacies now, even like CVS, have their own brands that they can purchase. They're not all that expensive. So one the night before and one the morning of surgery. And if you remember that slide with all of the 10 to the 2nd to the 11th, the different organisms in different parts of the body, you wanted them to come into your hospital cleaner. You want them bringing in these organisms from home, number one. So it's best that you just have them do those pre-op showers the night before and the morning of surgery to decrease the microbial load on the body before they undergo surgery.
Great. Thanks for explaining all that, Maureen. I think that's helpful for our audience to hear. The next question is, should ERAS protocols be instituted for all patients receiving general anesthesia in the OR?
I'm sorry, which protocols?
ERAS protocols, ERAS.
Oh, yeah. ERAS is a great program. That's fantastic that they pulled all those protocols together. And that, I would start there, to be honest with you, with the teamwork. That's something that I've shared. I've been doing a lot of work over in Asia with different surgeons and different countries over there. And we've been trying to, educate them about the ERAS program that we have. So that's something that your team has to sit down and look at your patient population and the various recommendations that they have, because there are different recommendations for different kinds of surgery. So it's a great place to start, as well as looking at the recently published guidelines from CDC in 2017, the WHO in 2016, and the American College of Surgeons in early 2017. So we're very fortunate we have not only national updated guidelines, but we have the ERAS protocols that are being recommended. Yes.
Great. Thank you for elaborating on that. Another audience member wants to know, what about skin prep prior to surgery in an ASC?
Well, I don't see patients going through ambulatory surgery any different than inpatient surgery. The time's going to be longer, but they have just the same risk of infection. The different devices, maybe they're doing more laparoscopic or ophthalmoscopic, and the incisions are smaller. The time of exposure is less, for sure, or they're healthier patients. There are clearly differences between them as far as the kinds of surgeries and the patients that are being done, but skin prep, it should make no difference. Standardizing to chlorhexidine and alcohol for the same reason I just mentioned, that you're going to get, I would say, you get more bang for your bucks when you use CHG, because it lasts on the skin longer than the povidone iodine. And so that's another reason for that. Just regular povidone like iodophor, the first one on the market was called Betadine way back. I remember when it first came out. That is about approximately a 2-hour, really good action. it kills bacteria in the skin, but it only gives out its action for about 2 hours. But when you potentiate it with alcohol, the like DuraPrep and Prevail, you get hours and hours of activity. Up to 12 hours, 10 to 12 hours. When you put CHG with alcohol, it can go beyond a day. So, even I've heard up to 2 days. So it's just a better antiseptic because of the way it works and binds to the cell walls of the organisms and kill them. So I would think that you use the same protocol as you're using. We did at the orthopedic hospital I worked on. Everything we did in inpatient surgery in the operating room, we did in the C-section rooms, and we did in our surgery center, where we did over 3,000 surgical procedures a year. And we did over 7,000 inpatient orthopedic cases, joints and so forth, spine, complicated spine. And their infection rate at that hospital was less than 0.3 for all surgeries. We were able to drive that infection rate down very low with our standardized approach, and standardized everything. And boy, the team, was so engaged. The team that I had, the surgeons were engaged. They don't want to see these infections. They're devastating to work with infections, especially in orthopedics. So yeah, use the same things you're using in your inpatient settings for these patients. They shouldn't be discriminated against. They should get the same, I feel, the same quacking with the alcohol.
Okay, great. And let me ask you a related question also about the ambulatory setting. This audience member writes, what are some quality metrics you see in ambulatory setting in surgery medical practices?
Well, I had an infection preventionist that worked with me in my ambulatory surgery center. She happened to be the OR director, but she was co-assigned to be what we call an IP. And so we had a post-discharge surveillance system. And each surgeon on a 2-month basis would get the list of all their surgeries. And we did this just nowadays, you just run these things off the computers. Back in the old days, they had to kind of print them out or send them cards. And you would then have to get those back within 2 months, within a month. And we would then calculate their rate and have that on our dashboard at our infection control committee at the hospital. So they should be collecting their adverse outcomes. We also, as years went on, when quality really started to get going with the slips and falls, the med errors, the skin breakdown, the whatever, pressure ulcers and DVTs and PEs, because infection control was already sending that information out to the surgeon, we just added in the other outcomes, with maybe healthcare acquired conditions that were being monitored, and asked the surgeons to let us know, so we could pass it on to quality. Did your patients also fall, or did they have a pressure ulcer and so forth? But we just combined the whole thing as we worked closely with quality to look at any adverse outcomes these patients were having. So, infections are important, but there are other kinds of safety issues as well that you can work with the quality department and collect that. And then integrate that. If you're an ambulatory surgery center connected with a hospital system, work very closely with them, their infection control program. But if you're freestanding, have your own sort of infection control committee and collect this kind of information from the surgeons and then present it. God forbid you have an outbreak because you didn't collect that information, and then, the media gets wind of it or the CDC gets wind of it. So it's really important that you're on top of it and finding out if there's any adverse outcomes from the surgeons to report to you.
Absolutely. Thanks for touching on all those metrics. The next question is, what process is recommended in the pre-op area? CHG wipes, then clip, or clip and then CHG wipes? This audience member added that they're having an issue in which patients are getting rashes if they have shaved recently and then use the wipes.
Yeah, definitely. We're seeing an increase. The FDA is actually maybe about 6 months ago actually reported that whole issue about CHG irritations. The key thing is that communication to those patients, whether it's in a written document or it's in the pre-op call that you get, to tell them not to shave their legs, for instance, and in their pubic area ahead of time, thinking they're helping you because they're going to have those skin nitises for infections, we call it. That's why we stopped razors, because they destroyed the skin level and they're more prone to infections. So if they, there's really no standard protocol about that. I would recommend not getting into the CHG after you do the clipping, because you're going to do the skin prep anyway, but not the wipes. The wipes, a lot of hospitals, especially inpatient, because they're a little expensive. They may be $5 to $6 for one of at least last time I looked, for one of those packages of wipes. Many of the inpatient settings, they're giving the patient the wipes before they come in because they're not sure if they actually did the shower. The patient might tell you they did the shower, but you're not really sure. So this is standardizing the approach to know that the patients at least washed off, cleansed off a good amount of bioburden before they went into surgery. And therefore, that would be actually before they got clipped as well. So that tends to be the protocol in inpatient. It's harder in ambulatory surgery centers, I know, because of your budgets and so forth, to add sometimes things that you are going to cost more money. But in the long run, just add up your infections, the financial bill that goes along with some of these infections, and see if you can offset it that way. By saying, that's what we used to do. We had a cost calculator and would cost out our infections at the committee so they could see how much infections cost. And therefore, some of these things we were asking for our infection prevention measures weren't off the wall. We were actually going to make that return on investment. So.
Great, thanks for clarifying that process. The next question is, once a patient has performed their CHG bath prior to surgery, do you recommend that they change their bed linens?
Oh, you mean like the bed linens at home? No, that's not really a recommendation that I know of anybody, or I can't even think of any studies that have looked at that people have gone into the home and, have cultured linens to say, I know linens grow organisms, that's for sure. We put off, just to give you a statistic, 10 million skin squames a day, and 1 million of those have bacteria. So that's why we always say in a hospital, 3 feet around the bed is the most contaminated area of the hospital. So if you're doing isolation, like in an ambulatory surgery center, because somebody's, got MRSA, we can confine and contain them in a cubicle with the cubicle curtain closed, because it's about 3 feet around the bed will get contaminated. But I know of no studies where they've gone into the home and cultured the linen to see how contaminated it was and recommended that they change the linen. Sounds like a nice idea, because they could then wash all those skin squames that are probably on that linen before they come in the next day for surgery. But I call that a low-hanging fruit. Yeah, it's like it's some things are just general sense sanitation, but the way healthcare is today for many measures is, where's the evidence? How does the evidence support that recommendation? Evidence-based medicine. But other times I just say, some things just make sense that you might want to recommend that they consider having clean sheets after they've done a decolonization of their body before they come in for surgery. Good question, actually. Never had that one asked before, whoever asked it.
Well, great. I'm glad we could ask a new question for you. Another audience member is wondering if you have been aware of the number of patient allergies linked to CHG. She said she had an adverse experience in which she had an allergy to it, and was just wondering your thoughts on that.
Yeah, absolutely. And just go on the FDA and search for CHG, and you'll see some information that's come out warning the public about CHG. We use a lot of CHG. Think of the ICUs. Every single patient in the ICU, most hospitals are cleansed with CHG. There's some literature indicating some resistance, developing a resistance, because whenever you overuse something, we know that with antibiotics, can happen with antiseptics, can happen with mupirocin ointment. The bugs are smart. They're brilliant. They will figure out a way to get resistant. And one of the other issues with the resistance is not just resistant to, say, CHG or mupirocin or an antibiotic. They can pass resistance to other antibiotics through these R factor, genes that they can pass along. So I had that problem where I'd implemented the CHG washcloths, the pre-op showers, rather than the bottle of solution. And boy, we had beefy red rashes, and I had surgeons down my neck saying, what the heck did you do to my patients? The problem was the back of the package of the CHG washcloths, for them to get those approved by the FDA, it was for a surgical skin prep, not the way we use them for general cleansing in, say, an ICU or prior to surgery. And it will say on the package, vigorously scrub for so many minutes. I think it might say 3 minutes. And yet the instructions that we give are gently scrub for 1 minute. We have to actually change the recommendation because it's an off-label use. So that's where some of the patients took those things and started scrubbing like crazy over their incisional site, thinking they were doing the right thing, and they just developed a skin rash. So we actually, in that setting, went back to the liquid. We found that having the showers with the liquid and having them keep it on for 1 minute had less reactions, and it was a little less expensive. And we reserved the washcloths for actually when they came in for the inpatient surgeries, not outpatient, but inpatient, to do those one additional cleanse before they went in the OR in the pre-op holding area. And they had many of the patients did them themselves rather than the nurses. But, sometimes we have so many obese patients, especially in orthopedics, that the nurses themselves said it's helpful for them because they know that they can get more bioburden off, say, the backside of the body for spine surgery. Some of these patients can't wipe themselves. They can't reach back, really cleanse the buttocks and so forth. So it gives the nurses another opportunity to make sure that they get a lot of that bioburden off before they go in for surgery.
Great. Those are helpful insights. Thanks, Maureen.
Yeah. Talk to the company, IFUs, and getting, again, why it's so important to work with industry reps, and they're trained in all of these products, the IFUs, and get them to come in and give in services and ask them these kinds of questions. And what do you recommend for the kinds of settings that we have in our patient population? Especially with the BD reps for the chlorhexidine with the alcohol, the ChlorPrep, and have them come in and work with you.
Great, and it looks like we have time for about one more question. This audience member says, can you make any comments about nasal decolonization in addition to the skin decolonization process?
Yes, favorite topic of mine. I lectured at APIC about this, and I've done some work on this area. So the state of right now, we have several vendors. One has an alcohol-based antiseptic, nasal antiseptic, and there are 3, I think it is now, with an iodophor-based and nasal antiseptic. And both companies have really good papers that have come out showing a reduction in SSIs, both of them in the orthopedic population. So that being said, the nasal one has that it has alcohol is a little bit of like a lemon in it as well, a citrus that they put in there, and it dries very quickly, has a nice smell, and patients tend to like that better than some of the iodophor ones because of the smell and the staining, but they work. So there's 2 options here. One thing we don't want to give the impression is that you could implement a universal decolonization protocol and stop screening patients for MRSA and MSSA. Right? In the inpatient setting, not outpatient, inpatient, that is really important that you screen for one reason. If somebody has MRSA, they need to get vancomycin, not cefazolin. So cefazolin is the number 1 antibiotic that's used for surgical prophylaxis, especially for clean surgery. So if you don't screen them, you're going to give an MRSA patient who's highly colonized all over their body. 80% of the infections in research that has shown the MRSA or Staph aureus that's in the SSI, they can match it up with the patient's nose. And here we are cleaning their body, CHG showers, skin prep, we forget the nose. So I've really come full circle on like, wow, I think personally we should be doing both the staff and the patient before they go into surgery. Just like we wash our hands. Well, what good is it if you wash your hands or sanitize your hands and you go back up and touch your nose and recolonize them if they're highly colonized? And they are, not just with MRSA and Staph aureus, but gram-negatives, fungus, other things as well. So that nasal antiseptic with alcohol does kill both gram-positives, gram-negatives, and fungus. So that's another area that I think your team should sit down and look at the data. You can get in touch with me if you want, I don't mind, and I can even send you some of the papers and a presentation on that particular topic. But we don't want that to replace universal decolonization in surgery, replace screening in the inpatient population. Okay, so let's get back to ambulatory surgery because most of you are from ambulatory settings. I would consider using that if I had a high infection rate and you had tried many of the things I talked about in your bundled approach and you still had infection rates. I actually had an outbreak in a NICU that we did everything, gowns and gloves, and kept cell phones out, and we put an antimicrobial product for the hands, and we couldn't get it under control. It was an MRSA outbreak until we put the nasal antiseptic with alcohol in place and had everybody coming into the NICU, visitors, doctors, nurses, therapists, whoever, had to sanitize their nose. We finally got that thing under control. So again, that's why you want to get infection control involved with any of your projects. And have them sit down and give you the data, and then you can make that determination whether it's worth the cost. And maybe only do it for a short period of time, until you get things under control, or you just continue to do a what they call universal decolonization. The good thing about them is they don't cost all that much. So that's kind of neat that you can implement something like that in ambulatory surgery settings where you don't screen. It would be just too cost prohibitive. We didn't even screen up in Boston at that, the orthopedic patients for ambulatory surgery, only inpatient surgeries because of the cost. So yeah, I can give you information on that, whoever asked about that question, if you want to get in touch with me.
Perfect. Thank you so much, Maureen. Before we go ahead and end the presentation, I just want to turn the floor over to you one more time, Maureen, to see if you have any final thoughts that you'd like to share with our audience.
Teamwork. The OR director can't handle this on her own, nor the infection preventionist. You have to have somebody high up, a key opinion leader, like somebody from the C-suite or the chief of service has to really be in charge of the team. I've learned that from my experience, that that's where you're going to get the clout, especially for changing practices, you know, having to deal sometimes with difficult people and bringing maybe in new products and having budgetary increases. So make sure that your team, when it's pulled together, it has the right resources from the C-suite.
Wonderful. Well, that is all the time that we have left for today. I want to thank Maureen Spencer for sharing her insights and for our audience for participating. We'd also like to invite our audience to our next webinar tomorrow, Wednesday, May 9th at 11 a.m. Central Time on intraoperative bleeding and reducing the incidence of bleeding-related complications. Look out for a follow-up email with a link to the registration page if you're interested. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.